Hello everyone and welcome to our afternoon webinar. Epilepsy Foundation of New Jersey is hosting this webinar being presented in conjunction with CNNH, the Center for Neurological and Neurodevelopmental Health. EFNJ is a nonprofit statewide organization dedicated to helping individuals with epilepsy and their families. We provide comprehensive support, personalized services, and advocacy for these families in order to maximize their participation in society. Please visit our website at www.efnj.com for more information or to sign up for our electronic newsletter. A recorded version of today's webinar will be available on both EFNJ and CNNH's websites. Our topic this afternoon will be the many faces of autism, differential diagnosis and sibling monitoring, presented by Dr. Sarah Woldoff of CNNH. Once the presentation has concluded, she will be happy to answer any questions you may have. The questions and chat bars are located on the bottom right-hand corner of your screen, and you may do so during the presentation or after it's concluded, but all questions will be answered at the end. To give a little background on Dr. Sarah Woldoff, she is a licensed psychologist with over 10 years of experience providing assessment services, individual treatment, consultation with schools and medical professionals, family therapy, and parent training for families with children on the autism spectrum. Dr. Woldoff received her doctorate degree in clinical psychology from Drexel University in Philadelphia, Pennsylvania, and completed her postdoctoral training at Jackson Memorial Hospital, University of Miami in Miami, Florida. She began her career as a behavior analyst at Children's Seashore House, the biobehavioral unit at Children's Hospital of Philadelphia. Dr. Woldoff also worked at the Center for Autism Research at CHOP, where she performed evaluations, supervised clinical evaluations for several research studies, co-led trainings for staff and school psychologists, and counseled parents. Additionally, Dr. Woldoff is skilled in the comprehensive psychological assessments of children, adolescents, and adults, particularly those with autism, specific learning disabilities, and other pervasive developmental disorders. She has presented on topics related to autism at numerous local and national conferences, including workshops on autism for families and educators. Additionally, if you are interested in signing up for CNNH's electronic newsletter, you may visit their website's homepage at www.cnnh.org and look for the sign up at the bottom of the homepage. Thank you, Dr. Woldoff, and you may begin.
All right, so good afternoon. I'm just going to set up the slideshow. So give me 1 second. All right, there we go. So good afternoon to everyone. As mentioned, I'm going to present a little bit on autism differential diagnosis and sibling monitoring. So we'll talk a little bit about some of the genetics with autism. I probably have more slides than needed, so we may skip a few. As most of you know, autism is really actually a neurobiological disorder of early brain development. If you ask insurance carriers, some will classify it medical. However, when you go to do treatment, many will classify it actually as a psychological disorder or a mental health disorder. But in actuality, it is a neurobiological disorder. And the reason why it's classified like that is it does seem to have to do with brain development. Their diagnosis of autism has really changed over the years, which we'll touch base on, and there does seem to be multiple mechanisms to autism, and that there definitely seems to be a biological basis, but not all cases are truly genetic by nature. But it really should not be thought of as a mental health disorder. previously in the past, the idea was that it was due to refrigerator mothers or cold parenting that led to autism, and we know now that that's not the case. There's also been a lot of discussion about vaccines, and we also know that that's not the case, even though it's quite difficult to debunk that theory at this point due to the number of people that kind of have got behind the idea that vaccines were contributing. In addition, what's interesting with autism has been the fact that the diagnosis is not dependent upon the etiology, meaning it's not dependent if there's a familial base, it's not dependent if there's a genetic base, that the diagnosis is purely built off of the actual diagnostic picture. The epidemiology of autism has changed tremendously. During my time at CHOP, I was able to work on the Cadre study, which helped to do some of the new numbers for autism. And really, the prevalence has changed, especially in the state of New Jersey. New Jersey actually has one of the highest rates of autism in the United States, with 1 in 50. Actually being diagnosed with autism. And it's important to know that that study actually accounted for people that moved to the state once they were diagnosed. So that's truly based on individuals born in the state of New Jersey and then later diagnosed with an autism spectrum disorder. In addition, as most people know, autism is much more prevalent in males than females. However, females that are born with autism tend to have a more severe or significant presentation of autism with greater delays. The original sibling incidence was 1 to 15, but we're going to talk a little bit about that. There's also similar rates across cultures. There's been a number of twin and sibling studies, which we'll talk a little bit about. And there's definitely increased risk with advanced maternal and or advanced paternal age. And there's currently a study that recently started that's actually looking at links between fertility treatments and autism. And some of the question that's been brought up is it the advanced maternal age of both the parents that have to do with the autism spectrum disorder, or does it have something to do with the actual fertility aspects? Clinical features of autism, while there has been significant changes in the DSM, the DSM-5 recently came out, which eliminated Asperger's and PDD-NOS as categories, and actually now created like a large umbrella of autism. But the clinical features have essentially stayed the same. There's the impairment in social interactions, so not being able to maintain peer interactions at a developmentally appropriate level. The impairments in the use of verbal and or nonverbal communication styles, restricted activities, abnormal interest, stereotyped behaviors such as hand flapping or spinning. The abnormal interest can range from things like an unusual interest in cars or stadiums to unusual interests in things such as sticks, ceiling fans, light switches, elevators. So it's really kind of a very broad umbrella. And the clinical features really help to define where the child falls in the spectrum based on their symptom presentation. There's a lot of different things that need to be taken into account when assessing for an autism spectrum disorder. There's a lot of overlap between autism and certain diagnosis, and that's where you really want to look into the differential diagnosis. So what you'll see on the next couple slides is just some of the disorders that there is some sort of overlap. So obviously cognitive impairment or an intellectual disability, language disorders, childhood schizophrenia, and actually now you can even think of childhood bipolar or pediatric bipolar disorder, anxiety disorders, ADHD, mood disorders, child neglect and abuse, sensory impairment, epilepsy, motor disorders, schizoid and schizotypal personality disorder, as well as dementia. With cognitive impairment, there's delays in skills compared to one's chronological age. And there are sometimes behavior mannerisms. The difference between an autism spectrum disorder and cognitive impairment is an individual with an intellectual disability, you might see some functional improvement with age. You might also not see the level of stereotypies and peering and obsessiveness that you'll see in a child with an autism spectrum disorder. And also with an autism spectrum disorder in comparison to a traditional cognitive impairment, you may see what we call splintered skills, in that you may actually see that the child with autism might have very strong nonverbal reasoning or matrix reasoning skills. So for example, a lot of the recent literature has actually suggested that a child with traditional autism who has significant language impairment, you may want to evaluate their nonverbal abilities more heavily than their verbal, and actually look at things such as their matrix reasoning or their nonverbal intelligence to get a better gauge of their functioning, due to the fact that the language deficits would cause them to perform poorly on traditional IQ tests. The other area, especially with younger kids, that you want to really differentiate is from a developmental language disorder. With young kids, a developmental language disorder would be impairment in expressive, so what you understand, what you say, receptive, what you understand in relation to their cognitive level. The differentiation from a developmental language disorder to an autism spectrum disorder might be that a child who has a language delay won't have any deficits in the use of gestures, which is something we look for in children with an autism spectrum disorder. In addition, a child with a language disorder may actually have intact play skills and social skills initially. Where you start to see some deficits is usually around the ages of 5 and 6, when language becomes so much more important to maintaining like a volley and a social interaction. In addition, a child with a language disorder won't normally have the presence of stereotypies that you would see in an autism spectrum disorder. And this is really important to differentiate, especially now that we're doing diagnosis between 18 and 36 months of age, is differentiating between just a traditional language deficit and autism proper. The other thing that we see is the ADOS, which is considered the gold standard for evaluating an autism spectrum disorder. Several studies have been done in the past by Leifer and also Kathy Lord that have actually showed that a lot of children who have a speech and language impairment may actually score higher on the social and communication algorithm scores than children in the pure speech and language impaired group. So in essence, kids who have a speech and language impairment could actually meet the cutoff score for an autism spectrum disorder if you were just looking at the ADOS. And that's why it's important to do a very in-depth evaluation using more than one tool. And this is another important aspect of an autism evaluation. You know, a lot of times I will have parents come in and say that, you know, they spent 15 minutes with someone and they diagnosed their child with an autism spectrum disorder, or ruled their child out of having an autism spectrum disorder. And this is where the importance of, you know, a really formal evaluation that involves several different aspects is necessary just to do an appropriate differential diagnosis, but also look at some of the biological factors that could be contributing, which we'll talk a little bit more about in a few slides. Another rule out is autism spectrum disorders versus nonverbal learning disabilities. Kids who have a nonverbal learning disability, which basically means that their nonverbal IQ is lower than their verbal IQ, they tend to present with a lot of social deficits that are similar in some ways to what you may see in an autism spectrum disorder. And this is why, again, it's really important to rule it out. Not every child with autism spectrum disorder will have an NVLD. And so not every child with an NVLD should also be conceptualized as meeting criteria for something like what we used to call Asperger's, or in this case we would now call high-functioning autism. The reason why this differential is also important is a lot of kids with NVLD, due to the fact that they have significant visual spatial deficits, they tend to have poor social skills because they have difficulty reading affect, interpreting social signs, and they also may actually have deficits interpreting their own body and space, so they may have poor social skills related to that. In addition, a lot of kids with NVLD also have poor executive functioning, so poor planning skills, poor initiation, deficits with attention, and those things also could lead to further impacting social skills due to the fact that they're not attending to other people and kind of scaffolding in the same way that a traditional child does. This is where it's important to do pragmatic language evaluations, so looking at prosody of speech, looking at understanding of metaphors, doing evaluation for theory of mind or perspective taking, looking at pretend play skills, as well as doing a really comprehensive history on what the child was like during the first 3 years of life to get a better gauge as to how their skills presented. And for example, the Autism Diagnostic Interview, known as the ADI, is really helpful in some ways for differentiating between a child that has a nonverbal learning disability and a child that has a true autism spectrum disorder. Another area that is commonly seen is anxiety disorders. It should be noted that in autism, the most highly comorbid disorder is an anxiety disorder. So a lot of kids who do have autism also meet criteria for anxiety disorders. However, a lot of kids, excuse me, something in my eye. A lot of kids who present with social anxiety disorder could also be mislabeled as meeting criteria for an autism spectrum disorder. The main difference is kids with social anxiety disorders typically have a pretty normal developmental pattern and usually have intact play skills. They don't normally have the unusual restricted interest or stereotypies, but they could have obsessive compulsive or perfectionistic features that could be present. The biggest differentiation, or the biggest thing to kind of understand in looking at anxiety disorders or social phobia or social anxiety disorder, is what typically happens is those kids feel very anxious in social situations, such as talking in front of a group, eating lunch in front of someone, breaking into a conversation. And so what happens over time in social anxiety disorder is the child kind of withdraws, and you may see deficits in social skills, but those deficits essentially come about from not practicing the social skill. So the way you can almost think about it is if you think of an athlete. So I'm a huge Phillies fan, so if you think of Ryan Howard, you know, he probably was a very good baseball player to begin with, but he had to practice his skill and refine it to become, you know, a major league baseball player. And it's the same way with social skills. If you're not practicing them on a regular basis, they're going to get rusty, and essentially, you know, you don't lose the skills, but they don't scaffold the same way developmentally. And that's one of the differentiations from social anxiety disorder versus ASD. In addition, a lot of the kids with social anxiety disorder have pretty good insight into their deficits, and they may actually have a pretty good understanding of emotions, but it's just more so their anxiety that keeps them from socializing with peers. OCD is another area that also has some overlap. The biggest thing to kind of recognize is in OCD as opposed to autism, you know, the obsession usually revolves around, you know, it revolves around some sort of obsessive topic. So sometimes it has to do with orderly, sometimes it has to do with cleanliness, sometimes we have people who engage in what's called checking behaviors. And there are features of OCD in autism, but not everyone with OCD has autism, meaning they might have pretty good social skills, they might have good affect recognition, they don't have stereotypies, but they do engage in that they have to line everything up, or they have to check everything 4 times. And so it may present as an obsessive behavior, but it actually has to do more with the underlying thoughts that are associated. So it's important to kind of differentiate the fact that they're engaging in the behavior to suppress anxiety and suppress the ruminating thoughts, not because it's a repetitive behavior. And the big area right now that I'm getting a lot of referrals is kids who truly have ADHD but are being either labeled as having Asperger's or being referred for an autism evaluation that they're not doing well socially with peers. ADHD, 60% roughly, according to the literature, have deficits in social skills who also meet criteria for ADHD. The reason why they conceptualize it that way is due to the fact the child's so busy or impulsive or inattentive that they don't really scaffold off of the other children. So they tend to not gain the social skills needed. So, a great example is the child who basically just kind of charges through and knocks down the other children's blocks. And he's just kind of impulsively doing it. And what happens is, that's viewed as a negative social skill or negative behavior. And that child, isn't attempting to be defiant or oppositional per se, but they are just extremely impulsive and don't know how to kind of self-monitor. In kids with ADHD is you see deficits in transitions. It's different. It's not related to the typical deficits you see in an autism spectrum disorder, but it's more the impulsivity, the inattention, the poor self-monitoring. The other things is there tend to be an inability to sustain appropriate peer play, because most kids with ADHD are very self-directed and they want to do what they want to do, and they don't really understand about the reciprocal components. The other thing too is that the social impairment in ADHD doesn't really apply necessarily to socialization as much as it does to other aspects of socialization like turn-taking and self-monitoring. Lastly, ADHD is associated sometimes with language deficits, sometimes with anxiety disorders and impulsivity. And a lot of kids with ADHD do wind up with comorbid learning disabilities, and they usually wind up getting programmed in the special education system for roughly 30% of their day. And a lot of the reasoning behind that could be related to, areas of the frontal lobe that we know is impacted in ADHD, as well as just the fact the child's so inattentive or impulsive that it prevents them from scaffolding in the classroom or attending in a way that they can learn effectively. Another area we also see some comorbidity is with mood disorders like depression. Depression's probably, again, one of the most frequent form of comorbid disorders we see in children with an autism spectrum disorder. Again, I talked about anxiety and comorbidity, and depression is the other one. A lot of kids, especially high-functioning kids with high-functioning autism, or what we used to call Asperger's syndrome, will experience high levels of depression because they're much more aware of their deficits. With high-functioning autism or Asperger's, a lot of times I'll conceptualize it as thinking about having one foot in the autism world and one foot in the typical world. And so you're much more aware of the deficits that you have and the struggles that you have. In addition, the symptoms of depression can kind of wax and wane in that sometimes, they might actually be on the upswing and things might be looking a little better, but then around transition time, you may see an increase in depression. But it's important to differentially diagnose between the two, because kids that are depressed will basically withdraw. They won't socialize the same. They may have a flat affect or poor eye contact. So it's important to differentiate and also to look at changes in sleeping and eating patterns, and also look to see if they have the typical normal development during the first 3 to 5 years of life, to see if this is really something of a change. The other thing is, in young kids with depression, they sometimes might present as irritable, so it's important to, again, differentiate there. And another big area is child neglect and abuse. Kids who are neglected or abused, who have been in the foster care system or who had multiple placements, again, they're often referred for autism spectrum evals, or sometimes they come in diagnosed with an autism spectrum disorder. And that's a little bit harder of a case because you usually won't have a good historian to review maybe the first 3 years of development unless there's some great records available. But one thing to be aware of is kids who are neglected or abused a lot present with what's called reactive attachment disorder. A lot have symptoms of withdrawal, both socially and emotionally. They may have atypical reactions to things due to the abuse or the neglect. So for example, there's a young lady we saw recently for an eval who's hoarding, and it was being viewed as, you know, an atypical behavior of autism. But when I went through the history, her family was not feeding her on a regular basis, and so she would go through trash and hoard any leftover food because she was responsible for not just feeding herself, but feeding a younger sibling. And so whenever anything went in the trash, she was compelled to get it out of the trash, and she would hide it in her room. But it wasn't really a atypical, obsessive, you know, unusual behavior. It was more an atypical reaction due to the abuse that she went through as a young child. They often experience language delays. They often will have anger or avoidant behavior. They might have limited play and imaginative play and poor creativity. So this is where it's really important to do a very comprehensive evaluation, try and obtain any records that are possible, and to really make sure that you're ruling in or out any possible disorder such as the reactive attachment disorder or developmental learning disorder, to really make sure you're doing an accurate diagnostic picture. Other disorders, visual impairments, hearing impairments. Kids with visual impairments will initially have difficulties with socialization, even though their language will be intact. Kids with hearing impairments may have poor speech development. They may have delays in gesture development, and they may have perseveration of gestures, play, or social skills. And a lot of that is more related to the sensory impairment as opposed to a true autism spectrum disorder. And the last two big areas are schizoid and schizotypal, or schizotypal personality disorders. There was an interesting article that came out not that long ago about the overlap, actually, between schizoid personality disorder and high-functioning autism. And what the study was saying is that a lot of individuals who have high-functioning autism will also meet criteria for schizoid personality disorder, and that it's actually a complicating factor for treatment due to the fact they have some personality traits in addition to having an underlying autism spectrum disorder. In schizoid personality disorder, the individual will have little desire for relationships. They prefer solitary activities, very few close friends, and they don't really identify a need for friendships. They put very little emphasis on being, you know, rewarded or reinforced, or even criticized by others. Very flat affect, you know, limited eye contact. And sometimes they might actually have like some paranoia, which is a little different than what we typically see in an autism spectrum disorder, where they actually may be a little bit concerned about peers, or thinking other people are against them and kind of have a very negative view. And it is important to differentiate between, you know, high-functioning autism or Asperger's and schizoid, as well as find out if schizoid personality trait is contributing to the diagnostic picture. The reason being is that's going to be a very large factor in treatment, because it's going to be much more difficult to address that in treatment when it's a core personality feature as opposed to part of the autism spectrum. The last is the schizotypal or schizotypal personality disorder. Schizotypal personality disorder, there's normally a normal developmental history. The features of this develop at a much later age, so that usually helps with the differential diagnosis. And a lot of times there's actually development of what we would call psychotic symptoms. which again is very different than what we see in an autism spectrum disorder. Individuals with this presentation, they might have odd beliefs. They're going to have a lot of the same features of schizoid personality disorder, meaning isolation, withdrawal, lack of seeking friendships. They may have odd beliefs or what we call magical thinking, ideas of reference, meaning that they think everybody's kind of hyper-focused on them, or they think people are out to get them. They might have a lot of that paranoia, and they might have some odd thinking or unusual speech patterns with their prosody. But again, with this, these kids typically have normal development, and you usually see the evolution of these features in later high school. So that should help, again, with the differential diagnosis. So those are the main areas of differential diagnosis that we always want to focus on or clarify. With autism currently, the average age at first concern, when there's been studies asking parents, like, when did you first identify that your child might have had something wrong with them? The average age that most parents voice a concern is around 15 months. And the primary concerns at that time are usually either language delays or social difficulties. You know, either they notice they're not making any babbling sounds, they haven't really evolved into first words or word approximations. And the social difficulties a lot of times have to do lack of eye contact, not responding to their name. And a lot of them, when we kind of go through the questioning and have them look back, for example, at the first birthday party, and we ask them questions such as, you know, how did they respond? You know, how did they respond to the birthday cake? How did they respond to all the people? You know, do you remember them being smiley in the pictures? You know, that's also where we start to see in hindsight, a lot of parents will say, you know what, I actually think, you know, problems might have been evident before that time. We also definitely see a difference in parental concern if it's their first child versus a second child. Clearly, if they have a direct means of comparison, they might be much more readily aware of some of the deficits or differences. And this is where the importance of early screening comes in, and this is where some of the changes have happened. You know, previously, autism was traditionally tended to be diagnosed between the ages of 4 and 5 for lower functioning autism, and higher functioning autism actually was being diagnosed as late as 8 to 11 due to the fact that the symptoms of high functioning autism usually bring a lot of pride to parents. So parents usually like the fact they're early readers, or like the fact they show an interest in dinosaurs or the planet. So those aren't really areas of concern, but it's usually around third grade when there's some deficits that parents would start to voice concern about the socialization or the fact they're rigid. With early screening, it's very important because obviously the prevalence rates of autism spectrum disorders keep going up. And part of the reason that we believe the prevalence rates have gone up is we have, you know, improved our ability to diagnose. A lot of people that maybe would be captured by other diagnoses in the past are now being more accurately diagnosed, as well as there does seem to just be a general increase in prevalence, which could be due to the combination of genetics and environmental contributions, which we'll talk about in a moment. We're now able to recognize symptoms as early as 12 months, and you know, being able to kind of track and target, which we'll talk about. And there's obviously increasing evidence that early intensive treatment for children with autism has a significant impact on outcome. So if you begin treatment early, the idea is you have a better outcome because you're focusing on so many of the skills at such an early age before a lot of them become more hardwired. And also you're working on it before there's more learned behaviors that have come into play. The screening tools and diagnostic tools that are used are the MCHAT, the CHAT, the Pervasive Developmental Disorder Screening Test, the CSBS, which is a caregiver questionnaire. There's the STAT, there's the ABC, the AOC, which is the Autism Observation Scales, the ADOS, the ADI, and the SCQ. So there's a lot of different tools that are utilized. The importance is understanding the difference between a screening tool and a diagnostic instrument. A screening tool does not provide a diagnosis. It's a good step to determine if a child should have a proper evaluation to determine if there's a diagnosis, and it's more flagging someone who you may need a proper evaluation, but it shouldn't be interpreted as meeting criteria for autism. It's more screening to see if a more extensive evaluation should be done. Things like the chat, the MChat, the STAT. The CARS is used. I will say that we don't feel the CARS should be used as a screening instrument because it doesn't really have a lot of specificity to it in differentiating between specific disorders. You know, the MChat is a good one, and that's the goal right now is to have every pediatrician office in the country completing a chat or a STAT in their office so that kids can be identified early who may need the eval. I don't think this is happening as of yet. I know that even my own pediatrician's office did not give me the MChat for my child, and I was actually a little bit surprised. You know, but it should be standard practice, and that's one of the goals right now is for it to become standard practice to allow for early diagnosis. How does diagnosis happen? Typically, it should be a clinical interview, developmental history, you know, the diagnostic observation instruments like the ADOS, or the AOC. If it's a young child, we recommend doing something like the Mullen Scales of Early Learning because that gives you motor skills, language skills, and nonverbal functioning. For older kids, we recommend a more formal IQ, such as the WISC or the DOS. We always recommend a language assessment and also looking at adaptive behavior. In addition, we recommend that a comprehensive neurological evaluation be done, you know, just to rule out any contributing neurological factors. We think that this is an important part because some of the genetics involved, the fact that there's a high correlation of seizure disorders in kids with an autism spectrum disorder, so it's important to evaluate that further. As well as to evaluate whether it could be another disorder that's presenting like an autism spectrum disorder, but that could be like epilepsy or that could be another functional disorder that's kind of mimicking like a mitochondrial disorder. The genetics of autism has become a pretty hot topic right now. There's clearly a genetic part to autism, you know, as we are seeing now that it's running in families, and that we're seeing families that have more than one child with autism. We usually call those multiplex families. We're also seeing that there are identical twins who, when you're identical, obviously, versus fraternal, you share the exact same genes. They're much more likely to have autism compared to fraternal twins. So identical twin studies show that if one twin is affected, there could be up to a 90% chance of the other twin being affected somewhere on the umbrella of autism. In addition, you know, the familial recurrence rates are a lot higher than expected given general population. So, you know, autism's now pretty common. If you have one child with autism, the risk for the next child to have autism is approximately 5%, so 1 in 20. The range actually says 2 to 6%. And if autism were due to a single gene, the numbers would be more like 25 to 50%. And thus far, we haven't been able to exclusively trace it to a single gene mutation. So we know that there's genetic factors, but it doesn't seem to be a single gene mutation. It seems to be related to, you know, several gene mutations or variable copies. So there was a large number of autistic individuals with unaffected family members. They say that that could actually vary because of the copy number variations on genes or deficits or spontaneous alterations in genetic material, meaning that one person, for whatever reason, had the genetic mutation, but the next person did not. The other thing is there has been some new research, so the High-Risk Baby Sibling Research Consortium, and this is a research institution in the US, Canada, Israel, and the UK, and what they did is they pulled data on 664 high-risk infants. So that means infants that have one or more biological siblings that were already diagnosed with autism, and they did this at 12 sites. And they found that 18.7% of siblings developed autism by 3 years of age, and 26.2% of boys versus 9.1% of girls. So again, the incidence does seem to be higher in boys than girls. Among boys and girls who had multiple older siblings, so more than one, an average of 32.2% of the infants developed an autism spectrum disorder. So again, that's a lot higher than what we expected. So if you have 2 children with autism, the chance that the third will have autism is around 32 to 35%. And so this basically implies that lots of different genes are involved, because otherwise the rates would be very, very different. Another way to kind of explain a lot of these results is if autism aren't in other people in the family tree, meaning it just appears out of nowhere, that clearly tells us that it's not purely related to one gene, or else you would be able to hone in, figure out which gene it is, and you would kind of see the discrepancies. So, this isn't as unusual as you would think. DNA changes from generation to generation. We see this in cases of dwarfism, where you'll see it kind of change from generation to generation. We see it in Crohn's, where it might skip one generation, but that generation is the carrier. So you really will see a lot of these differences. Autism and multiplex families, which again means families that have more than one child with autism. There was a study in 2008 that compared genes linked with autism to those of other neurological disorders, and they found that more than half of known autism genes are actually implicated in other neurological disorders. So again, it suggests this molecular mechanism with autism. Another study was of 99 autistic programs, and that found that 2.9% for autism in siblings, and between 12 and 20% for a lesser variant of autism, meaning the sibling might have had severe autism and they have a more mild presentation. And one possibility that's being explored right now is the interaction of genetic predisposition and what you can think of as an environmental trigger. The IBIS study is a study I got to work on in the early studies, another one I got to work on, but the early study is one of the first studies that's actually looking at the combination of genetics as well as environment. So the early study is looking at how environment may actually influence the flipping the switch, per se, of an autism spectrum disorder. So it's trying to look at, environment changes in the home, medications you took, and the IBIS study is a sibling tracking study that's been ongoing for a couple years now that has some pretty interesting results that should be released hopefully in time to come. So what does this all mean? Basically there definitely seems to be a genetic correlation in autism. Is it in every case? Probably not. Is it in a lot of the cases? Probably so. It's very difficult to have insurance companies cover genetic testing, and the way that we usually do genetic testing, specifically with an autism spectrum disorder, but with a lot of other disorders, is we do genetic testing on the child, and then if there's a genetic abnormality there, we will then do genetic testing on the parents to see if either of them have a similar genetic trait. If they have the same trait and they don't have autism, then clearly that gene isn't involved, and that's part of the reason we then look at the parents. So what does this mean is that basically sibling monitoring needs to be a hallmark of basically care in families that have a child who's diagnosed with autism. So if you have one child diagnosed with autism, we suggest that if you do have a second child that you start monitoring and you initiate that at 6 months of age. It should include a developmental and a neurological evaluation, and then essentially a tracking system, very similar to what they do in developmental follow-up clinics for babies that were in the NICU, where we would do an evaluation at 6, 12, 18, 24, and 36 months. And that way we can look for any of the hallmark symptoms at a very early age, and also be able to track any developmental changes or developmental lags, and then be able to refer out to early intervention or related services. With a lot of the new tools that are out there, like the AOC and the CSBS, we can actually do pretty complex evaluations at 6 months of age, which allow us to look for some of the behaviors. Rebecca Landau and her group of researchers and several others have found that kids who go on to develop autism later in life, when looking back at videos of them at 6 months, some of the behaviors were already present. She had shown a great clip of one child who had a repetitive interest in spinning his bottle, on an angle, and he did it all the time. And it was really appearing, and repetitive interest type behavior. But at that point, it was just kind of deemed as, something he engaged in. Other things you can look at that age are eye tracking, joint attention. Young babies will provide evidence of joint attention at a very young age. Most of you who have children, you can think about your child would look at the bottle, look back at you, look at the bottle, or look at the breast, look back at you, look at the breast. And right there, they communicated, we're hungry, feed us. So joint attention begins at a very young age, and it's one of the hallmark symptoms that we're able to kind of track at that very young age. The biggest thing right now is there is a genome project where they're trying to encourage families who have a child with autism to basically donate their DNA to a bank, where they're trying to be able to get a large number of subjects to be able to really delve into the genetic findings of autism and see if they can find some DNA changes across large samples to get a better idea of the contributions that are contributing to the presentation of autism. What I'll do now is, that's kind of the bulk of the presentation. What I'd love to do is, if anyone has any questions, we could start to address any of those or any comments.
Thank you very, very much, Dr. Woldoff. That was a great presentation. We do have some questions lined up already. So the first question is, how do we get credit for this?
That's a very good question.
I'm sure if we don't know the answer right now, we can talk afterwards.
Right. With Sandra or someone here and see how that would go.
Sure, we can certainly send an email out to all registered attendees to let them know. Okay. The next question is, please explain matrix skills.
Okay. So matrix skills, or, matrices, the way to think of it, are basically like abstract visual spatial skills. So, for example, you can kind of think of a visual picture that's missing, one piece of it, and you have choices at the bottom, and you basically would kind of scan and figure out which piece is the missing piece. So they're basically visual spatial puzzles that have pieces missing out of them. And what we find is a lot of kids with an autism spectrum disorder actually have really strong visual spatial skills, and that's why a lot of them are very visual learners and do better with things like visual schedules or visual prompts. So that's basically what the matrix, aspect of nonverbal intelligence is.
Okay, thank you. Next question is, why is the rate of autism higher in New Jersey than any other state?
And that is a good question. There's a gazillion theories. I don't think anyone really knows. There's some theories I'm sure people have heard of regarding, like, there's also a higher incidence of breast cancer in certain parts of New Jersey. And there's a question about environmental triggers. So the area, for example, that has higher rates of breast cancer in New Jersey is an area that has, you know, higher waste and toxins in the area, and part of the area was actually built on a toxic dump site. So some of the questions that remain are, is it the environmental trigger then that's kind of flipping the switch? And no one really knows the answer to that question. It's one of many theories, but that's, you know, I think one of the things that they're trying to explore in some of the new research, such as the early study, is the environmental contributions to autism.
Okay, great. Next question is, can we have access to a copy of these slides?
What we could do is I can scan and send them to you as a PDF, and then if you want to forward them to anyone on, you know, the email list, that's fine with me.
Absolutely. Okay, we can do that. We'll do that along with the directions on how to get the credits for this.
Okay.
Next question. Is there a type of medication that is used to treat schizoid personality disorder?
And there's no magic bullet for that. You know, there's been some question of, you know, and again, this isn't my area of expertise, but I can speak to it based off of just some of my work with individuals. A psychiatrist or a neurologist would probably be best to really answer it, but you know, some people have done well with antidepressants. Some people have done well with medications like Abilify. It really depends on the individual's, you know, clinical presentation, as well as, you know, the affect presentation. So it really would vary from person to person. So there's no perfect, you know, magic bullet type treatment. It really would have to be individualized based on the presentation.
Okay, thank you. Do you know what the comorbidity rate is for seizure disorders and autism spectrum disorder?
I believe I'm looking at my notes. Hang on. Some had it as high as a third, and yeah, I think it's roughly anywhere from 33, and some studies have it as high as 58%. But there was a large-scale study that was done postmortem on epilepsy and autism, and they found that roughly a third of the brains donated actually showed signs of epilepsy. You know, there is a question, there's this theory of now about subclinical spikes, which are small spikes, but roughly a third of kids with autism, though, have and meet the full diagnostic criteria for epilepsy. And now one of the other things that's being looked at is also mitochondrial disorders and autism, because there's now a belief that a lot of the quote-unquote like GI symptoms that you might see in a child with an autism spectrum disorder may actually be related to a mitochondrial deficit. And there's now new testing. You used to have to test for mitochondrial disorders by taking a spinal tap, but you now can do a cheek swab and be able to test for mitochondrial disorders, which could allow for you know, another aspect of treatment, because sometimes if it's mitochondrial, you might be able to use enzymes and different types of treatments.
Wow, I'm certainly learning a lot. Thank you. Next question is, have you seen moms with autoimmune diseases and autism?
We have. We definitely have. I mean, there's no clear studies on that particular topic, but we definitely have, you know, I'd say in our office seen so.
Okay. The next one gives a little background before asking a question. I work in a preschool. Too often the teachers and administration recognize or suspect autism, but the child study team will not evaluate because the child has shown some growth. What is your opinion about this assumption?
I think you're always better to err on the side of caution. Even if the child has shown some growth, it's important to kind of have that differential diagnosis because it also kind of gives you a pathway for the future. Meaning, Brenda Miles has a great book called Rage and Rumbling, but she talks a lot about kind of the variable path that kids who are on the spectrum sometimes take with emotional regulation and things like that. So even if they've made some growth, if they truly meet for a diagnosis of an autism spectrum disorder, it can direct other therapies that you could be utilizing, as well as, kind of educate the parents on the course of autism and that, there might be some great periods and then during some transitions they might have some tough times. And you can also start to be a little bit more proactive by working on executive functioning and social skill planning. So that it's really, you do a disservice to the child by not doing the referral, because even if you're wrong, at least you referred for it to kind of rule it in or rule it out.
Okay, thank you. Can an adult be diagnosed with autism and be treated?
Yes, we've seen several adults actually who I've diagnosed. When I see an adult for an autism eval, it's always helpful if there's either a parent or a sibling. The reason being is a lot of times if the parents are still, around and cognitively intact, I love to do a parent interview using something like the ABI, just to find out about development the first 3 years of life, find out about, some things when they were younger, social skills when they were younger, to really get a good handle on the first 3 years of life. And then in addition, there's different tests. So we can obviously do an ADOS with an adult, but we can also do affect recognition, theory of mind testing, some other social perception testing, pragmatic language testing. So there's lots of different evals we can do. We've seen a lot of adults. I'd say I've only diagnosed a handful as truly meeting criteria for autism. But we've also recently seen a lot of 21-year-olds who made their way through the high school system but definitely had autism, of younger adults who, we've seen a large population who had kind of the mild form or Asperger's high functioning and kind of just got missed. And now as a young adult is where you're really seeing more deficits because they really can't function outside of that structured school environment.
Okay, thank you. We have a child at my school. He's 5, has no social skills, makes very little eye contact, and is not able to communicate in a clear manner. We are trying to get him an appointment with a neurologist, but the wait is about 5 months. Why does it take so long to get an evaluation? Do you have any suggestions? Is the school district financially responsible for the screenings?
That's an interesting question. So one of the reasons I came here and why I like it here, like we can get people in pretty quickly. But it's a drawback. It's a flaw in the system. I've worked at other places where it's 18-month wait list to get the kid an autism evaluation, which is, horrendous because that's 18 months that a parent loses for intervention. Now in New Jersey, I know because several of the schools, we're contracted with them and we actually do the autism evaluations for them. And we do it with the neurologist as well as with the neuropsychologist as a combined eval. And in those cases, the school is being held responsible for that evaluation. So I think in some cases it does fall on the school district if they think that there's a suspect of autism to, do the evaluation. But I also understand, from other districts, it depends on the age of the child. If it's an older child, they could, mention it to the parent and do, their part of the evaluation and then recommend the parent follow up with the neurologist. So I think it varies, depending on the district and depending on the age of the child. But I know that we do a lot of the evaluations for about 4 districts that I know that we're contracted in. We are contracted with the child study teams to do like 20 evaluations for the year, you know, that involve both the neurologist and myself combined to do a comprehensive.
Thank you.
It's just a flaw in the system.
Okay, and I'll also say, to piggyback on Dr. Woldoff's answer, we, on our website, in addition to the CNNH docs, we have a listing of statewide neurologists. So if you're finding a roadblock, might try another area. The next question is, can a young boy that had an in utero brain bleed present with autism-like behaviors, and then the behaviors which are autism-like, be treated as autism, or is it better to tease out all the symptoms and treat separately?
That is an interesting one because, you know, an in utero bleed can basically be seen as traumatic brain injury in essence. So, you know, it would all depend on what was the level of the bleed. Was it like a level 1, a level 2, any other complications or concerns? And then I would want to do, you know, more of a proper eval to determine if it's, you know, an autism spectrum, or is it something more along the lines of what we would call cognitive disorder, not otherwise specified, meaning that the deficits that are apparent are more related to basically a traumatic brain injury is the way you can kind of conceptualize it, or a brain injury in utero. So it would be important to kind of differentiate, only because if it's, and also we usually would recommend too, probably I would think doing an MRI as well, just to see what everything looks like to make sure that there's nothing organic now, because usually they'll do an MRI as an infant if you had that type of development, but we usually would do that just to rule in or rule out any specific type of brain damage related to that could account for the symptom presentation.
Sure. Next question. Do moms who have an autoimmune disease have kids with autism, and is there a relationship between the two?
There's no known relationship at this time. Like, there's been several different, you know, research studies recently about advanced maternal age. There was another one about being on SSRIs when you had a baby, and whether being maintained on that actually had a higher incidence. So there's no, you know, known correlation at this point. There's nothing specific pointing to it.
Okay. What age is high-functioning autism generally diagnosed, and how much more difficult is that to diagnose at the younger, under age 3 age?
So with high-functioning autism, it's actually, when you're younger, the pattern would pretty much be clear. And what I mean by that is, you know, typically like the language development would be there. When we do the nonverbal testing, there'd be, you know, pretty intact what we call nonverbal reasoning skills at that age. A lot of times, though, high-functioning autism, and even like the low-functioning autism, you don't usually close the door, I would say, on development until a child's a little older. So for example, if I evaluate someone at 3 and they're testing as, you know, a language delay as well as poor nonverbal reasoning at that time, and they also do meet criteria for an autism spectrum disorder, I'm not going to pigeonhole them into low functioning or high functioning at that age, because they're just going to start services. But if I see that same child at, you know, 7 or 8, and they still have low IQ, they still have some of the same deficits, you know, I'm more comfortable then kind of pulling the trigger on, you know, giving a comorbid intellectual disability or giving a diagnosis of like low functioning autism, or what we would now call moderate or severe autism. But usually between the ages of 2 and 3, you know, again, you don't want to pigeonhole someone because they're just going to start the therapies, but you want to really start to track that person. So I usually recommend tracking them every year to see how they're making progress and to tweak basically their treatment plans. But I've had a couple cases where in 6 months it looks like a totally different kid, where we may reevaluate it 6 months just to get a better gauge of response to treatment.
Okay. What about ID versus autism IEP diagnosis? What are the major differences?
So, the difference between an autism diagnosis and an intellectual disabilities diagnosis?
I believe that's the question, yes.
So, not every kid with an intellectual disability is going to have autism, and not every kid with autism is going to have an intellectual disability. So kids with an intellectual disability, you're not going to see splintered skills typically. Typically what you'll see are deficits both in verbal and nonverbal skills. Kids with an intellectual disability will also have comorbid deficits in adaptive functioning. They may not have the mannerisms and repetitive behaviors like you'll see in autism. Kids who carry an autism diagnosis could be completely cognitively intact with very high IQs and not intellectually disabled by any means, but they may just have social deficits. A good way to conceptualize this is there's a classroom that I'm in a local school district, and there's kids in that classroom who are intellectually disabled, and there's also kids in the classroom with autism. One of the children who I work with who has autism is nonverbal, does not socialize with anyone, and just kind of will hang on his own, but he's pretty good with math and can just buzz along with mathematics on a computer-based program and does awesome. Whereas a couple of the other kids in the class who are pretty significantly intellectually disabled, they can't do the math, but they're much more social than he is. And they want to find out right away why I'm there and who I am, and they ask me like a million questions. But cognitively, he's well above them, even though socially he's well below them. So it really is a very differential diagnosis, and it gives a different clinical picture.
Okay. Would you be able to go to your neurologist or family doctor to talk about adult autism?
Yes. Yeah, you definitely would be able to go to neurologists. Now, the one thing I will say is there's not as many adult neurologists who I think would be open, so you'd want to find someone, who understands autism as well. Like our practice, for example, we have adult neurology here who specialize in, migraines, concussions, autism, but they're adult neurologists, so they kind of understand the spectrum. Whereas traditional adult neurologists, a lot of them don't work with individuals who have spectrum disorders. Part of the reason CNNH began as a pediatric practice, but we've now expanded, is because basically all of our clientele who are pediatric, once they hit adulthood, they have no one to go to because there's not very many neurologists who specialize in developmental disabilities or autism for adults. And so that's the caveat, is finding someone who kind of has that dual specialty, who would be open to the idea of exploring an autism spectrum disorder in an adult.
Okay. Is rage common with children with autism?
I don't want to say it's common, because you could say rage is common with anyone. But Brenda Miles has a very interesting book, as I mentioned before, about like the rage and rumbling cycle, and she's actually identified kind of this pattern with especially high-functioning kids with an autism spectrum disorder who will kind of hold it together at school, and what will happen is when they come home, they kind of unravel. And we do see that fairly often. We see a lot of kids, some high-functioning kids who are very into routine, and they get upset if kids in their class like break the rules, and they may lash out as a result of that. But I also see non-autistic kids who are low frustration tolerance and fall into rages and things like that. So I don't want to, say that it's just within autism, but we do see some behavior dysregulation patterns in kids with autism. But not every child with autism is going to have the same pattern of behavior dysregulation.
Right. Okay, this one says, what do you suggest for a student who is refusing to do work at school? His writing is illegible. The teacher says he's choosing not to work. He has many diagnoses, including Asperger's, anxiety, mood disorder. Also threatened to commit suicide and kill the principal. But the school says he does not qualify for special ed services.
I often see writing is usually a big trigger for a lot of kids who have an autism spectrum disorder where, I would see accommodations. I would see, what about if you use dictation software? What if you use support of a computer? Like DragonSpeak is the dictation software, which is really useful, and some people can alleviate a lot of the stress associated with writing. Could there be work with him on breaking down writing assignments into smaller components? Could there be a tokening system or some sort of reinforcement system built into working for very short intervals? There's programs like Kidspiration, Inspiration, which are graphic organizer programs. Could something like that be utilized to assist him in creative writing? Could we link areas of his own interest to the written expression assignments? I mean, there's different things that could be done. Just because you don't meet formal diagnosis for a specific learning disability, if his writing is horrific, it sounds like he may have dysgraphia. So could he have an OT evaluation to determine he has dysgraphia and then determine what accommodations would be appropriate? And then the stuff with threatening to kill others or threatening to kill himself, we have a lot of kids who sometimes will use those type of things loosely, and we work with those kids on understanding the true ramifications, that if you say you're going to kill yourself, you'll go to crisis, and what that means, or if you say you're going to kill someone else, that there's police implications for that and what that could mean, and helping them to understand kind of the ramifications of making statements like that, and then teaching them alternative coping skills to utilize when they're frustrated, or alternative coping skills to utilize when they're feeling overwhelmed. So I think that that's a situation where a child might not meet the traditional diagnostic, and again, I've never tested him or seen the data, but could he have a specific learning disability just in the area of essay composition and therefore qualify for some services due to that deficit?
Okay, is there any relationship between autism spectrum disorder and ACC?
ACC.
I
don't know what that means.
I'm not sure, but if the asker would reiterate what ACC means, we can come back to that. But the next question is, why, when a child is diagnosed with epilepsy, there is no immediate testing or evaluation for autism when they are sometimes linked together?
That's a good question. I don't know the answer to that. That's a very good question, especially I think if the child shows any overt signs or possible signs of an autism spectrum disorder. We also suggest that any child who has epilepsy, also have a neuropsychological evaluation done, just because of the comorbid deficits in processing speed, working memory, and executive functioning that are often observed in epilepsy. So that's a good question. I mean, our practice is a little bit different because I think we try to do a neuropsych on any child with epilepsy, but I know that's not necessarily, typical. But it is something that's worth doing, especially to further evaluate some of the deficits that are commonly seen in epilepsy, such as working memory, processing speed, visual memory versus verbal memory, as well as motor planning, initiation, cognitive flexibility. Those are all areas that we tend to see impacted in kids with epilepsy.
Okay. I understand that there are many children that quote-unquote fall off the spectrum, often many of them initially being misdiagnosed, in parentheses, with some of the similar conditions that you spoke about, that perhaps contributing to the high statistic of individuals with autism. Is there any study that confirms the amount of children who ultimately recover from autism or who are misdiagnosed? I understand. Oh, and then it just repeats itself.
Yeah, there's none that have, there's no specific study. There was one study that just was recently done that was looking at individuals who are adults diagnosed as schizophrenic in a state hospital to see how many of them actually met criteria for an autism spectrum disorder. And there were a few, but the number was actually a lot smaller than we expected. But there's no specific research that kind of captures either misdiagnoses or kids that maybe were diagnosed at 3, but then at 11% more like ADHD. So there's no specific study at this time that really captures that. There's just kind of more anecdotal stories or experiences about that.
Okay.
One of the questions I have is now that they're doing early diagnosis, where we're diagnosing kids at 18 months, is whether or not that will be better captured.
Okay. So we've heard back from the other asker about ACC, agenesis of the corpus callosum.
Okay. So I know that there has been some cases where there is ACC as well as autism, but there's nothing solidified. There was a recent study that was more about the cortex. That was really interesting. It didn't get any airplay, which is very sad, but it came out a couple weeks ago. It's out of California, the study came out of. But again, it was a post-mortem autopsy study where they actually did autopsies on several individuals who had passed away who also had a diagnosis of autism. And they actually had found that the layers of cortex, which kind of looked like a layer cake, had pieces missing or layers missing, which really showed that autism definitely, not every case, but out of these cases, that the autism definitely happened in utero because the brain development happens during the second trimester. So it was an interesting study and the first of its kind to really show the fact that, in these cases of autism, it definitely was a in utero factor, which helps to kind of redirect some of the ideas that vaccines cause it, because again, these findings are all based off of development that occurs during the second trimester. But there's no definitive studies at this point regarding ACC and autism, same as there's no definitive regarding some features of brain development. So for example, there's some studies that have found that the amygdala and the fusiform gyrus are actually associated with autism, some deficits in the amygdala and fusiform gyrus, but it's not every single case.
Okay. There's a question that asks about this recorded session and if you're going to have access to the recording. So I can answer by saying, yes, afterwards we'll have this recorded and the webinar will be posted on both Epilepsy Foundation of New Jersey and CNNH's websites. So I'll say for EFNJ, it will be listed under a tab entitled Webinars. And I don't know, Dr. Woldoff, do you know where on the CNNH website webinars are usually listed?
I'm not sure. Normally there's like a drop-down bar on the right side of the screen that shows workshops and webinars, so I'm assuming it would be posted there.
Sure. Okay. All right. And for those of you who were in attendance in the beginning of the webinar, the CNNH's website is www.cnnh.org. And Epilepsy Foundation of New Jersey's is www.efnj.com. All right, we do have some more questions here. I have seen child checklists for autism and also for ADHD. Are there checklists for adult signs as well?
There are not checklists for adult signs, but there is, there's something called the SCQ, which is the Social Communication Questionnaire, and that asks a lot of questions regarding like the ages of 4 to 5 years for parents to think back. So if there's a parent or a family member, the SCQ would be really useful just to see, it's a screening tool to see if there's a significant response. But there's not many adult checklists, actually, that kind of explore the possibility of a spectrum disorder per se.
Okay. Is non-focal seizures common in children with autism?
Yes. That's one thing that we're seeing is non-focal seizures. And then, we're also now looking into subclinical spikes as well in correlation with autism, but also with other neuropsychological conditions too.
Okay. All right. Someone says, my son was at CHOP at age 16 with onset of epilepsy, and I did tell the doctor I believed he had autism. They dismissed it because of what the 16-year-old told them and acted like in front of them.
And, and that's where, again, I would recommend doing a comprehensive assessment, where you have someone do a formal evaluation. Because I think often, sometimes it's dismissed because the kid might look great during, the 20 minutes that you're with them or the 30 minutes that you're with them. I mean, I've even had cases here where the parents are reporting one thing, I do the evaluation, the kid's not looking so bad, but so then what I'll suggest doing is going and doing a school observation, and then I get a very different view of the child once you see him with peers. So what I would suggest is if it didn't meet your expectation or it didn't really address some of your questions, is to seek out another opinion or another comprehensive evaluation where they'll actually do, the ADOS, the ADI, maybe do a school observation to really get a better handle on it.
Okay, thank you. That is the end of the questions that are listed here. If anybody has additional questions, you can reach us from either of our websites, contact information. Again, we want to thank CNNH and Dr. Woldoff for presenting this fantastic webinar. Thank you so much. And again, we'll get you the directions to obtain this credits as well as the PowerPoint slides. So again, thank you, CNNH, and thank you, Dr. Woldoff.
Thank you. Have a great day.
You too. Take care.